patients' lives. We can distinguish three types of shocks: appropriate shocks, unnecessary shocks, and inappropriate shocks. Appropriate shocks, that the shocks are triggered by potentially life-threatening arrhythmias, so is necessary shocks. You can understand this type of shocks cannot be avoided by programming because ventricular arrhythmia is not terminable by another means. Unnecessary shocks are appropriate shocks, but we can avoid them by programming in the future. We distinguish two types. Shocks are delivered for ventricular arrhythmia that could be terminated by ATP, including fast ventricular tachycardia, and shocks delivered for non-sustained ventricular tachycardia. Inappropriate shocks are triggered by inappropriate detection or inappropriate rhythm interpretation, mostly supraventricular tachycardia. How to decrease rate of shocks? For inappropriate shocks, we must avoid detecting supraventricular tachycardia as ventricular arrhythmia. So we must set the rate of ventricular fibrillation zone and set the discriminators properly. And we must avoid detecting other fast rhythms or noise as ventricular tachycardia by using discrimination algorithms. How can programming the ventricular arrhythmia detection zone? If we look in this histogram, we can understand that below 180 beats per minute, we have in majority of cases supraventricular tachycardia, includes sinus tachycardia. Up to 230, we have in majority of cases ventricular arrhythmia, VF, ventricular fibrillation, or ventricular tachycardia monomorphic or polymorphic. So in programming of zone detection, we must begin with for VT zone, we start in up to 180, and for VF zone, we program up to 230. In this interval between 180 to 220, we can observe it all type of tachycardia, ventricular arrhythmia and supraventricular arrhythmia includes sinus tachycardia. So in this zone, we must program all discrimination algorithms. So we have we have the recommendations, consensus for learned societies for primary prevention and for primary prevention ICD patients. The slowest tachycardia therapy zone limit should be programmed between 185 and 200 beats per minute to reduce total therapies. And discrimination algorithms to distinguish supraventricular from ventricular tachycardia should be programmed to include rhythms with rates faster than 200 and potentially up to 230 beats per minute. And it's recommended to active lead failure alerts to avoid inappropriate shocks. What are for unnecessary shocks? What can avoid unnecessary shocks? to avoid detecting non-sustained ventricular tachycardia and to minimize shocks for fast ventricular tachycardia. It's possible by prolong the detection delay therapy and to use ATP. We begin with prolong the detection delay therapy. For these algorithms, many studies, non-randomized, randomized studies for primary prevention or for primary and secondary prevention, all these studies compared short detection or conventional programming to prolonged detection interval. And all these studies proved that prolonged detection intervention reduce inappropriate shock, reduce appropriate or unnecessary shock, reduce the mortality. For example, PREPARE is non-randomized studies. This is proved that shock episodes, appropriate or inappropriate, were reduced by 63% if we used a long detection interval. And it was an impact on mortality. In fact, in PREPARE, we reduce mortality as compared as a control group. MADIT-RIT is a study sponsored by Boston Scientific. They compared it's a randomized study in 3-arm conventional programming, high rate programming, and a long duration delay. This study proved that if we combine high rate with a long duration delay, we can reduce for 75% first inappropriate therapy. And this reduction of inappropriate shock decreased mortality. ADVANCE-3 is a randomized study in primary and secondary prevention. Delaying ICD therapy longer reduced unnecessary therapy by 37% and inappropriate shocks by 45%. The recommendation we recommend in class 1 for primary prevention and secondary prevention, the detection duration should be programmed to require the tachycardia to continue for at least 6 to 12 seconds or for 30 intervals, so long intervals. For ATP, what can ATP reduce our unnecessary shocks? This study, or prospective study, non-randomized, showed that 77% of fast ventricular tachycardia were terminated with ATP and without increased rate of arrhythmia acceleration or rate of syncope. So that proved that ATP is efficiency of ATP to terminate fast ventricular tachycardia with safety. We return to ADVANCE-3. This study combined ATP during charging to a long detection interval, and that proved that the shocks are reduced by 52%. Finally, in this paper, we compare burst to ramp therapy, ATP. And we proved that with burst, we have more ATP success and less rate of arrhythmia acceleration. From where we have this recommendation. So, in all patients with structural disease, ATP therapy should be active for all zones of ventricular arrhythmia, include up to 230. And if we use ATP, burst therapy is preferable to ramp therapy. In my conclusion, ICDs are proven to save lives, also with the current patients and current medication. Delivering a shock, preventing sudden cardiac death is essential, but we need to make sure that shocks are delivered only to save life. In order to reduce number of shocks, several strategies should be combined. One, prolonging the detection or delaying therapy. Two, programming the discriminators to as high rates as possible, ideally up to 230, using ATP to avoid unnecessary shocks, and using discrimination algorithms to avoid inappropriate shocks. And the recommendations of learning societies are in place to guide physicians on the optimal ICD programming. Thank you.
Thank you very much, Dr. Krishen, for this relevant and very nice presentation. We move immediately to the next presentation, which will be presented by Professor Abdeldaim Haggi from Military Hospital of Tunis. This presentation will deal with the subcutaneous ICD. Haggi, you have only 10 minutes. Nico?
Okay, thank you very much, Mr. the President, and good morning, dear friends and colleagues. It's a real pleasure to talk about an exciting subject as the subcutaneous defibrillators. I take this opportunity to thank the organizing committee and the rhythmology working group for appointing. This is my disclosure. First, and before discussing the advantages and the disadvantages of this device, it's crucial to define it. It's an automatic defibrillator with the same function of a transvenous defibrillator, which are the detection of arrhythmia and then defibrillation. The significant difference is the lead. It's entirely subcutaneous for SICD, and it's endovascular for the transvenous defibrillator. The SICD was designed to minimize complication related to vascular access. These complications can be observed in the perioperative phase as pneumothorax, hemothorax, hemopericardium, dislodgement of the leads, and in the long-term thrombosis of the veins, late dislodgement and systemic infection. The long-term reliability of the lead is compromised by the biophysical constraints imposed by the heartbeat and by the costoclavicular clamp, which can damage the lead and cause its rupture. Regarding the reliability of endovascular leads, the rate of lead fracture is over 20% at 10 years, which is already huge. Now I want to talk about the history of SICD. In 2002, the proof of concept study began and the first generation SICD system was born. The SICD system gained market approval in Europe 2019 and in the United States of America 2012. Launched in 2015, the emblem SICD system was 20% thinner with 40% greater longevity compared to the first generation and was enabled for latitude remote monitoring. The Emblem MRI SICD system is the latest generation. It's labeled for 1.5 Tesla full body MRI scans and includes two new features, Smart Pass technology and AF monitor. Smart Pass is a high-pass filter designed to reduce T-wave oversensing, will help ensure patients receive appropriate device therapy when needed by enhancing the insight algorithm, and the AF monitor is a new detection tool designed to alert physicians of silent or new onset atrial fibrillation. This is a schematic representation of the position of the can and the lead. The can is located at the level of the left axillary region. The lead has two portions, one horizontal parallel to the fifth intercostal space and one vertical along the left edge of the sternum, more rarely the right lateral edge of the sternum. This position allows to generate three vectors called primary, secondary, and alternative, and which enable the analysis of the cardiac electrocardiogram. But before deciding the implant of SICD, it's essential to do a screening. Screening is used to check whether the patient has a suitable signal for the proper functioning of the SICD, thus allowing the best sensitivity and specificity of the identification of the rhythm and reduce the risk of detection, which is the main cause of inappropriate shocks. The number of SICD implantation continues to grow worldwide, and several patients of them has been included in clinical trials. The first clinical trials to validate the concept was EDE, which included 321 patients. These studies have clarified the position of the SICD in European and American guidelines. The EDE study was a multi-center study which included 330 patients and which aimed to study the efficacy and safety of SICD with a follow-up ranging from 6 to 12 months. The defibrillation rate during DFT test was successful in 100% of patients. At 6 months of follow-up, complications were observed in 8% of patients. There were 4 cases of infection of the compartment which required extraction of the material. This complication was particularly observed in the early stage of the learning curve for implantocardiologists. The second trial was Effortless, which is an international multi-center registry that included 472 patients with various heart disease and representative of all indications for ICD, ischemic heart disease, dilated cardiac disease, channelopathy, hypertrophic cardiomyopathy, and arrhythmogenic right ventricular dysplasia. The complication rate at 1 year was 6%. As you can see in these details, complications were in some from technical issues and for others due to infection. For inappropriate shocks due to oversensing, programming dial zone reduced this complication by half. The first meta-analysis pooling data from EDE and Effortless has shown that inappropriate shocks were not significantly different from the major clinical trial with ICD as MADI2, Definite, SCODA Shift, and MADI-TREAT, specially designed to reduce inappropriate shocks by prolonging detection and using higher frequency of detection. Now we will go to the most recent clinical trial. The Praetorian is the first clinical trial in a typical ICD population published this year and aiming to compare head-to-head transvenous ICD with SICD in terms of major ACD-related adverse events, inappropriate shocks, ACD-related complication that requires intervention, and lead-related complication. Praetorian included more than 100 patients randomized in 1-to-1 to receive transvenous ICD or SICD. Furthermore, as you can see, the two populations were similar. Ischemic cardiomyopathy represents the two-thirds of indication, and primary prevention was about 80% of indication. After 4 years follow-up, the incidence of the primary composite endpoint, which inappropriate shocks and complication, was 15.7% in the transvenous ICD and 15.1% in SICD. The difference is not statistically significant. When we look at the appropriate shocks, we get the impression of a higher trend with SICD, but statistically it remains insignificant. I draw your attention that 78% of inappropriate shocks happened while the smart pass option was unavailable or disabled. However, the superiority of SICD is the reduction of complication related to the device, especially the lead, 9.8% in the transvenous ICD versus 5.9% in the SICD. The inappropriate shocks observed in patients with SICD were increased by the phenomena of cardiac and non-cardiac oversensing. And if we assume that smart pass algorithm was running, inappropriate shocks would be less frequent with the SICD compared to transvenous ICD. So, in terms of operative complication with SICD, we observed fewer infection, fewer thrombotic events, less lead displacement, zero pneumothorax, zero perforation, and zero tamponade. But more bleeding was observed, maybe related to the richly vascularized anatomical region and to the relatively large can of the device compared to transvenous ICD. What about mortality? After 4 years follow-up, mortality was similar in both populations, 16% and 13%. There are some limitations in Praetorian study. First, physician, patients, and clinical events committee were not blinded for treatment allocation. Secondary, physician implant experience was higher for transvenous ICD, and last, the median follow-up of 4 years may be too short to reveal the real chronic complication with ICD therapy. Now, the study Untouched. This study aimed to understand outcomes with the new generation of SICD in primary prevention patients with low ejection fraction. This study demonstrates high efficacy and safety with contemporary SICD device and programming despite the relatively high incidence of comorbidities in comparison to earlier SICD generation trials. The inappropriate shock rate is 3.1% at 1 year. It is the lowest reported for the SICD and lower than many transvenous ICD studies using contemporary programming to reduce inappropriate shocks. But about the guidelines, in 2015, after the publication of the results of EDE and Effortless, the ASC task force published the first guidelines with 2 levels of recommendation. 2.1, SICD may be an alternative to the transvenous ICD in patients with an indication for an ICD without bradycardia, need for CRT or ITP. 2B, SICD is a useful alternative for patients with infection, difficult vascular access, and in young patients with a long-term need for ICD. 2 years later, in 2017, AHASHA, SCC-HRS, has published the new recommendation, and SICD gained 1 class to be class 1 indication in patients with difficult vascular access or at high risk of infection, and in whom pacing for bradycardia or BT termination or as part of CRT is neither needed or anticipated. So the strong indication for ICD are young patients, primary prevention that we need just a shock to save a life, patients at high risk of infection or with poor vascular access. The clear contraindication for SICD are bradycardia and CRT. Finally, the need of ATP still controversial, and more analysis are needed to clarify the role of either SICD or transvenous ICD in these patients. The prospects of ICD, I think that pioneering and untouched the new clinical trials may change the USC guidelines in the future. And I think SICD will be +1 indication. To conclude, SICD is a less invasive solution. Advantages of SICD are effective defibrillation without vascular complication, low risk of systemic infection, reduction of lead-related complication, and thank you for your attention.
Thank you very much, Professor Hagib, for this very nice presentation and exhaustive presentation. We move to the next presentation with Dr. Amna Alouche from Charnicol Hospital, Tunis. His presentation was entitled, "Is there still a place for defibrillation in primary prevention in the area of new therapies for heart failure?" 10 minutes. Amna?
Le son est coupé.
Thank you, Professor. I'll try to.
It's okay. You can start, Amna.
I can't share my screen. So you can see it. So thank you for this opportunity, dear faculty, for this opportunity to be there with you. I'm so glad to be part of this course, and I was asked to answer, is there still a place for ICD therapy in primary prevention in the area of new therapies for heart failure? So patients with heart failure have an increased risk of sudden cardiac death owing to malignant arrhythmias. 2 randomized controlled trials testing ICD use for primary prevention of sudden cardiac death have shown that ICD reduced sudden cardiac death and improved survival in those patients. These trials are MADET2 and SCADA-SHIFT. Therefore, both American and European guidelines recommend ICDs for primary prevention in patients with heart failure with reduced ejection fraction. But both trials enrolled patients more than 20 years ago and may not reflect the characteristics and the current management of heart failure with reduced ejection fraction. Recent advances have impacted the risk profile of patients with heart failure with reduced ejection fraction, leading to a reduction of sudden cardiac death risk over the past 2 decades. Paradigm HF trial concluded that ARNI was superior to enalapril in reducing both sudden cardiac death and death from worsening heart failure. BERA, by focusing on very long-term survival and late sudden cardiac death in resynchronization therapy patients, showed that progressive heart failure death still represent the most frequent cause of death, and in contrast of sudden cardiac death, there in yellow, represents a very low proportion of late mortality in both groups with or without ICDs. In this recent meta-analysis, Chen analyzed data from 12 clinical trials spanning of the period from 1995 through 2014. They excluded patients with ICDs, and we see that the annual rate of sudden cardiac death is decreasing in rails, which terminated in 1998 from 6.5% to 3.3% in Paradigm, which terminated in 2014. So the rate of sudden death has declined by 44%. The decline in the rate of sudden death over this period paralleled the increasing use of evidence-based based pharmacotherapies that are known to reduce incidence of sudden death. So what about the contemporary prophylactic ICD therapy benefit? Let's see some new data. And the Danish trial proved that ICDs in patients with non-ischemic heart failure did not provide an overall survival benefit. Cardiovascular death were equal in the two groups, but sudden cardiac death, the risk of sudden cardiac death was halved with an ICD, and the European Committee made this study the EU CRT ICD prospective trial, which was an investigator-initiated, non-randomized, open-controlled, multi-center cohort study. The randomized trial is not possible to do because it was judged unethical, and this committee aimed to assess present-day benefit from prophylactic ICD therapy. The large majority of patients in both groups received heart failure medication according to the ESC guidelines. And we can see that sudden cardiac death was considerably lower in ICD group. And the adjusted difference in survival between the ICD and the control group was 27%. The usefulness of the ICD was unevenly distributed in the overall cohort and was highly reduced in patients over 75 years old and diabetic patients. Analysis of data from the Swedish heart failure registry, which focused on the association between the use of primary prevention ICDs and mortality in patients with heart failure, they find that only 10% of eligible patients had ICDs, and the ICD use was associated with 27% reduction in all-cause mortality during the first year, and with a 29% reduction during the first year in the risk of cardiovascular death. For follow-up of 5 years, ICD use was associated with a 12% reduction in all-cause mortality, but cardiovascular death there was no significant reduction. And finally, as a take-home message, the current recommended medication of heart failure with reduced ejection fraction, including ACE inhibitors, AR blockers, ARNI, beta blockers, and MRA, and CRT use, if indicated, reduce the risk of a sudden cardiac death. ICDs for primary prevention purposes, as recommended, are underused in actual real-world patients with heart failure. Primary prophylactic ICD treatment showed a 27% survival benefit in actual typical European heart failure patient, so it has still a place in primary prevention. But for our specific African economic and demographic context, studies have to be initiated to evaluate our current practice and make our own guidelines. Thank you for your attention.
Thank you very much, Dr. Alouche, for this very good presentation. So I will give to Professor Senaweli the floor for any question or any comment from the audience.
Thank you very much, Dr. Ben Amer, for this opportunity. I am very proud to be here with you, and I congratulate the arrhythmia group, working group, for this brilliant topic and brilliant session with brilliant presenter. And we congratulate also PAFCIC organization and our collaborator, our Boston Scientific. So I have, there is no question, but I have questions. And I have questions for the three presenters. The first question is for Salma, Dr. Salma Krishen. So if you combine RF ablation with ICD implantation,
do you think that we can reduce more the appropriate shocks, and we can manage our patient with we reduce the appropriate shocks. Inappropriate shocks, I'm agree. We should have higher zones and longer zones when we program. For patients with appropriate shock, we should combine the two therapies.
To avoid unnecessary shocks, you mean that to avoid unnecessary shocks?
Yes.
Unnecessary, yes. Yes, I think that, but we must, this therapy is for special patients, for patients who have the same ventricular, monomorphic ventricular tachycardia, recidiving, that recidive with the optimal medical therapy. So if the patient receive all the time therapy, shocks or ATP. In my presentation, we proved that ATP therapy, the patients who receive ATP therapy have a more mortality than a group without therapy. So better mortality than group receive shock, but they have high mortality if we compare them with patients not receive therapy. So if we can avoid unnecessary therapy shocks or ATP, it's all the time benefit. So radio frequency ablation for VT, recidive with the optimal therapy medication is a very good indication. If we have the possibility to ablate VT, so we must have an experience for this. Good experience electrophysiologist who can do this therapy.
Thank you very much, Dr. Krishen. I have also a question to Dr. Hagi. Dr. Hagi, do you think that we should implant in all our patients who don't need pacing, even if they are they have no high risk of infection, and even they are not younger? If we have the possibility to do that, do you think that we should now implant all our patients when they don't need the pacing?
Good question. I think the good indication for SICD, young patient, are primary prevention to avoid complication due to the leads in a high risk patient of infection as prostatic valve, diabetes, renal failure. But now the concern of SICD is the cost, threefold effective, threefold than a conventional ICD. We will still implant transvenous ICD for bradycardia patient 30 and some patient due to the cost. But in ideal world, where the cost is equal to the conventional ICD, I think 50% of patients need to be with SICD. The advantage of SICD is due to the lead, and now with the recent study, preterm and untouched, as you have seen, the reduction of inappropriate shocks also with the new algorithms, Smart Pass and AF monitor.
Dr. Can I?
Yes, of course.
I think there are still some imperfections of the SICD system, and mainly citing the problem of T-wave oversensing and noise caused by massive potentials even with the smart pass. The battery longevity is also a limiting factor for the subcutaneous ICD. The absence of Holter function, also the cost, which remains high compared to transvenous ICD. And finally, the great handicap is the inability to deliver pacing therapy. And I have one question. We know that there are certain experiments which combine SICD and leadless pacemaker. Can you tell us, Dr. Hagi, about these experiments?
Yes, this is the future of the SICD, the combination between leadless pacemaker and SICD. So leadless pacemaker will assure the pacing for bradycardia patient, and the SICD only just for to shock a patient. This is the future. I have no experience in this. Maybe our friend Dr. Harbiya more experience. Have you the experience to combine leadless pacemaker and SICD in your experience?
Hello. Yes. Hello. So before talking about the SICD and the leadless pacemaker, actually we had a case with a patient who has a dual chamber pacemaker who needed an upgrade for a defibrillator, and we just we left this the dual chamber pacemaker, and he didn't, we did injection, we didn't have any anatomy to put a lead, and he's completely dependent. We don't want to extract, so we did an SICD for him. So we put an SICD for this guy on top of his pacemaker, like we did the regular sensing, and it did really fine. So this is one. But just to talk to the other part, the ATP and the leadless pacemaker and the SICD, actually, I don't have any personal experience, but there are some people who are doing it, and it's still under trials in the US and the Europe. They are going it, but the results should be promising.
About sensing, T-wave sensing, the failure of screening is about 8%. So when we can't select patient, so we indicate transvenous ICD.
Thank you. Thank you, Dr.
I just want to have one comment. Sorry, one comment. Just because this is a very important comment for the Praetorian, Dr. Haki know about it. So they said, okay, we were expecting such results, but we were like kind of, we had a bit higher kind of percentage of inappropriate shocks than the usual. And if you dig more into the trial of the Praetorian, you can check that this is mainly related that 50% of the SICDs were implanted are from the older ones, and 80% of the devices that didn't have this smart pass option. Maybe this is one of the factors that you can see that the percentage is a bit higher than the regular.
Thank
you.
Thank you very much. I have a question to Dr. Emna Alouche. Dr. Yusuf Amr, you can ask the question.
Yes. If you I have a question for Emna Alouche. Effectively, do you think that the only selection criteria for ICD based on ejection fraction is sufficient, especially in non-ischemic cardiomyopathy? So what do you suggest as another criteria, MRI, for example, or Holter or SPP?
For more screening.
Yes.
I think more screening is useful to select good patient who would be advantages by having an ICD. I think we have to do MRI search to detect scars in non-ischemic cardiomyopathy. Non-diabetic patients are advantaged in having ICDs. Younger patients under 75-year-old get more benefits from ICD. So we have to find some scores or some clinical other criteria in the adjunction of the EF the left ventricular ejection fraction to find patients who would have more, who would we save lives for them.
Emna, I have a question, a practical question, please.
Yeah.
If you have a patient with non-ischemic heart failure, wide QRS, and he's have an optimal treatment, do you implant a CRTP or CRTD? In your, of course, in our economic situation.
In our economic situation, we try to have the MRI. If there is no scar, we implant CRTP. If there is a scar, we try to have the ICD.
One question for Salma Krishan, Dr. Salma Krishan. Salma, we know that some VF and or polymorphic ventricular tachycardia episode may be seen at rate below 200 beats per minute. Yes. We know also that Boston Scientific device, for example, is not be able to discriminate in VF zone, and they are able to discriminate only in VT zone. So my question is, it is safe to program only one VF zone for primary prevention, or you recommend to program also VT zone to avoid detecting supraventricular tachycardia in the zone where the device cannot discriminate?
Effectively, this is a very good question. It's recommended to open two zone. Also for primary prevention to detect fast ventricular tachycardia and to detect also slowly polymorphic ventricular fibrillation. So it's recommended to, but if we open this zone, VT zone, we must start up to 185 beats per minute to 220, and VF up to 230. So I agree with you. It's recommended. This programmation is recommended to avoid, but it's not the same for all manufacturers, for all type of device.
Yes. Thank you very much. There is a question from the audience, Afif bin Halima, and she asked, what about elderly? Is there a threshold age for defibrillators?
What?
In elderly, is there a threshold age to implant an ICD?
In UA study, they concluded that the patient more than 75-year-olds, there is no benefit from ICDs.
So we can change our guidelines in Tunisia.
I think heart failure, guidelines of heart failure and CNAM, there is an age threshold for our CNAM.
Cutoff.
There's a cutoff, yes. I think 70 years.
For our CNAM is 65 years, but it's very...
65 years?
Yes, not 75 years.
We are so younger, 65 years.
Yes. They in the retreat and having education for primary prevention and not getting ICD.
In few years, we will have 65, dear Hagi.
Yes. Time go faster.
The one that we did just after the retreat, just after stop working and dead.
Okay.
Okay.
There is no... Dr. Rashida Bouhouch asks, she said, she commented I think we need to consider physiologic age rather than chronological. Yes, of course.
I agree.
I agree, yes.
Mm.
Yes, yes. Okay.
Thank you for Rashida Bouhosh.
We can move?
Yes. I pass the moderation to our president, Professor Shabrak, to continue with the technical lecture.
Okay, we move to the practical aspect of biventricular resynchronization therapy, and we will start with Bernard Harbiyi from Lebanon, who will share with us his experience in CRT through some challenging cases. You have the floor, Dr. Harbiyi.
Thank you so much. Thank you for the PAFCIC committee. Thank you for the arrhythmia group in Tunis. Thank you, dear colleagues and friends, for this. So today, what I'm gonna do. This is a 10 minutes or a 20 minutes talk.
Between 10 and 15 minutes.
Okay. Yeah, because they told me 20 minutes, that's why I asked it. So I will try to go quick. Okay, so what should we do when we have a challenging venous anatomy? Okay, so when we have a difficult or complex coronary sinus, it should be different than a poke and pray approach. So we need to have some catheter manipulation, we need to keep doing some small puffs of contrast just to locate the CS, and then we need to use the wires for support. Definitely we need specific tools like vein selector and contrast injection system, but sometimes you don't have the luxury of doing this because some are costly. But when we go it is very important to have a wide spectrum of catheters in order, or delivery systems in order to cannulate the CS and the branches from the CS. Why is that? So because it's really important to look at the echo for each patient and decide what to do. Before every CRT, I like always concentrate on the right atrial size and the size of the heart of the patient in order to decide what delivery system we use. Because like from the Acuity from Boston, we have like, for example, at least eight different shapes. The least one I use is the straight, because actually I don't see there is any real place in this straight unless in very small cases. Adding to the delivery system, which is a 9 French outer system, it's very important to have a vein selector, the inner catheters. The inner catheters are really important just for support. And I will show you some cases that we need the inner system, because if you don't have, even if you cannulate the CS and you have a good branch, sometimes advancing the lead in a branch without an inner catheter is really difficult and will give you a hard time. And sometimes you can have the whole system out of the coronary sinus if you don't have a good support. So this is why it's important. The advantage of vein selectors, they are atraumatic, they have a soft tip, you can just manipulate inside the coronary sinus. You don't have really much to worry about dissection or anything like this with the vein selectors, and you can just use them, just give a smaller amount of contrast just to cannulate the branch. And they are really flexible. One of the techniques that used when we have complex anatomy, just you have to be comfortable while doing the procedure. So if it's possible just to have the table as perpendicular to the patient. But sometimes we don't have the luxury to have the monitors just in front of us. So this is sometimes impossible, but this will help with kinking of the catheters and for managing difficult cases. Wire techniques, whenever we have some cases which are difficult to do, it's important to have a good support with wires. Why? Because this is helpful when you have an unstable coronary sinus axis, when we have coronary target veins near the os, and this is where you are at risk to have the catheter outside the CS, and when you need to advance a tortuous branch. So this is, for example, whenever you have this inside the coronary sinus, just don't lose time. I know that many just try first to do a puff without anything. Don't lose time doing puff without anything, just without a balloon, without an occlusion, because this is too much contrast. This is more X-ray radiation. This is more time in the procedure. You can do it sometimes when like you have the wire going in an ideal branch directly. Sometimes you can argue maybe I don't do anything, but just don't lose time because this is all time loss for the procedure. Another, when you have a patient, for this is a patient who had an LV lead, but this patient had phrenic pacing with all combinations. So whenever you want to revise this lead, before just pulling it out, it's very important to secure the coronary sinus with a wire. This is very important. Also, this is another patient with a mechanical mitral valve. You can see just by looking at the X-ray how huge is the right atrium. And whenever it's a huge right atrium, this is the delivery system to use and what are the inner catheters to use, because you sometimes you can see where did we access the coronary sinus. So this is really important to know the anatomy before starting your procedure. So this is a case where like you occlude the vein, the coronary sinus, and you look at this. Oh, this is a disaster. You know that you'll not be able to advance anything, but you should always, whenever you have this, you have two options to do. Just when you inject the balloon and you start doing the cine, just give it some time, even until give it time to see if there is anything, any retrograde filling. Or when you look, always just don't lose hope. Just go back. You should definitely have some mid-lateral vein or a posterolateral vein. So this is not something that you should worry about. No, you need to look for another option. Why is that? Because you expect to have the other vein somewhere lower, okay? Because if you cannot rely on these branches, because you will never be able to put a CS lead in a good target vein, okay? So this is another example. You can see this example. This is a very nice anatomy. This is okay. You can say, okay, I will advance a wire here and I will advance the lead. But if you don't do it without a vein selector, it's gonna take you double the time. So why is that? Because if you advance, let's say you advance the wire went all the way to the branch, but you can see you have this angulation here. We have here. So we know that even if the wire is here, when trying to advance the lead here, you know that our catheter, our delivery system is gonna go back and you're gonna pull everything out. So if you just advance an inner sheet or a vein selector and just have it here inside the vein, like 70% of your hard work will be gone, and it will be smooth and better. So this is very important to know. Whenever you have this, let's go and put a vein selector. So this is an example of a previously failed implant. Okay, so this is you can put a lead here. Okay, but they tried, they could not advance it. So, but just simply at putting a vein selector here, we have just by crossing this one here, we're able to advance a lead in this branch. Okay, so this is another example where you have a large posterior branch. Okay, but whenever you have this, you should be careful about phrenic pacing, about lead stability, and the apical lead position for short QRV. And whenever you advance to this, always keep a wire as a support. So this is an example of a single. So you occlude the vein here all the way up, and you can see here, this is not a good target vein, but if you keep the cine till the end after the injection, you can see that we have something here. Okay, so this is where you say, oh, okay, I need to go back, I need to pull progressively and maybe to occlude here and just to advance it through this one. Okay, so this is why it's important to give it time when you inject your cine after occlusion. So this is another example of an acute angulation in the target vein. Okay, so whenever you have this acute angulation, you know that it will not work without an inner catheter. So you need an inner catheter, okay? Because without an inner catheter, you will not have a good injection first, and you will not have a really how to direct yourself what to do, okay? This is, so we know this anatomy, and this is the second important step is to know what type of lead you need to choose. For example, in this example here, you can see that this is a big vein. You need to choose a long tip lead. However, if you look at this one, you need to choose a short tip lead. Okay, so because a long tip lead, will not help here at much. You will not have you will not benefit from the 4 electrodes that you have at the leads. And this is exactly in this branch here. You have a short tip lead as compared here. You need a long tip leads. This is another example. When you can have a long tip lead. So if you're targeting this branch, though we prefer not to, but if sometimes it's targeting this branch, it's tortuous and short, try to go for a straight lead, not to go for a curved lead. Okay. This is another example of what type of leads you need to choose. The bigger the lead, the bigger the branch, the longer the branch. You need to choose a long tip lead. The shorter, the more curved. So you need to choose a short tip lead. So this is an example of a venogram, okay, that shows a tortuous lateral vein, okay. By using an inner catheter, you will be able to advance a short tip lead, and it's wedged inside the lateral vein. Okay, this is an example where a long tip lead was wedged in the posterior vein. Okay, so I'm just showing you this is an interesting example. So this is a patient who was referred for an upgrade for a biventricular pacemaker because he had a tachycardia and pacemaker-induced myopathy. So we need to upgrade to add an LV lead. So what we did, we had really a hard time just to find the coronary sinus. So we used different catheters, and we used inner catheters. We need AL2, we need different catheters. And you can see here, if you look here, we did a lot of injections, okay? And one of the injection, so when injecting here, we saw some whiff going up, but there is another image that I could not download that we show that there is something going up here. So we decided, okay, maybe this is a interesting case that we can go look, maybe having another way to advance the coronary sinus. So we went all the way back up and we start injecting the vein. Okay, and you can see here, when injecting here, you can see that we have a whiff of contrast going this way down. So once we advanced the inner catheter and we injected the inner catheter, you can see that we have a contrast going all the way down here. So we advanced a wire, and the wire went all the way down. So, and we advanced the catheter, then we advanced the delivery system, and here that we injected, and now we can see the coronary sinus. So what we did, we just simply advanced the lead from this branch here, and this is the final X-ray of the patient. So this is an oblique vein of Marshall, which runs along the posterior left atrium and joins the great cardiac vein at the point where the latter becomes the coronary sinus. Okay, and just an image of the oblique of the anterior cardinal vein. So we can see this is the brachiocephalic vein, this is the right atrium, this is the regular coronary sinus os. So whenever we have a failure of the left anterior cardinal vein to regress into the ligament of Marshall, this will result in a left superior vena cava draining into the coronary sinus. We're having the lead inside. It's not about only having the lead, it's about only to know how to slit. This is very important. You can ruin all your work just simply if you don't know the techniques of how to slit it right. Okay, it's very important to hold the cutter hand stable, okay, on the table, and pull the hub back to engage the cutter. And once initiated, you pull the catheter back and away from the lead, not towards the lead. If you pull the catheter straight back towards the lead, you're gonna pull the whole system out. It's very important to pull the catheter away from the lead. So this is important. So patience is the key in CRT implantation. There are several approaches needed. If one fails, vein selector help for support. I will end up my slide with this picture that I took from one of the platforms for cardiologists and electrophysiologists. You can see this guy with 3 different devices. In order to know what is this, I know most of you are connected to the EP Connect. The EP Connect is this is a platform for electrophysiologists and cardiologists that they can go and create an account, and you can share cases, and then there will be discussions between just cardiologists and electrophysiologists about this case. Thank you so much for your time.
Thank you very much.
Thank you very much, Dr. Harbiya, for this very nice presentation. And now we move to our dear friend, Dr. Najmuddin Al-Shahidi from France. He worked as head of electrophysiology department of Centre Hospitalier Universitaire de Limoges. And actually, he works at King Faisal Hospital and the Research Center in Riyadh. He will talk to us about the CRT best practices optimization for heart failure patient. You have the floor, Dr. Shahidi.
Thank you very much, dear Sonia. It's really a great pleasure for me to be here today with you. I would like to thank the organizer for having invited me to participate actively in this really very exciting meeting. I attended several sessions yesterday. It was really very nice. I would like to thank as well Boston Scientific for the organizing this symposium. So far I learned a lot since I started to attend different sessions. Since the 17th of December. So I was asked to talk about CRT optimization in heart failure patient. It's really a huge topic. And just as introduction, all of us, we know that CRT is really a valid therapy prescribed in heart failure with reduced ejection fraction in patients presenting with wide QRS and who are still symptomatic despite of the optimal medical treatment. So we have to consider this really seriously before even thinking to implant any device in our patient. We have to be sure that they are on optimal pharmacological treatment. However, even if it is a valid therapy, we are still having something like up to 30 or 35% of patients who are not responding to CRT. And optimization will be indicated mainly in those patients who are not a responder. Most clinical trials reported at least 30 to 35% of non-responders as here, whatever the trial you are considering. And even if we are considering the endpoint, which is measured in different trials, this non-response could be up to 50% if we are considering, for example, here the remodeling measures coming mainly from echocardiographic data, and this is mainly due to the lack of a standard definition. We don't have unique definition about which patient is responder, which patient is not a responder. So if we ask the question, regarding pharmacological treatment, for example, ACE inhibitor, beta blocker inhibitor, I can ask you, do you really know what is the rate of non-responders to pharmacological treatment, to ACE inhibitor, beta blocker? It's almost the same. It's around 30%. So regarding the non-response to CRT, is this 30% finally a constant non-response, whatever the therapy we are applying to our heart failure? So we'll try to answer this question. Is this 30% because patients are not optimally selected? We'll see. Is this 30% because they are not optimally implanted, or because they are not finally benefiting from optimization? Assuming all these questions, we assume that our patients are on optimal medical treatment. I will never insist enough on this part. Several factors were reported to be associated with suboptimal CRT response or non-response. But the most frequent here is the AV delay, which is really need to be programmed adequately. The occurrence of arrhythmia during the follow-up, when the patient is not paced 100% of time in biventricular mode, if the patient was not correctly selected, and we are still seeing such patient, and we have some possibility of interventions to resolve this, this problem. You know, optimization should be considered at each step of a CRT therapy. And it is starting at the pre-implant phase. We have to select adequately the patient, which one will be most likely to respond to our treatment during the implant. And we just saw with the previous speaker that how it is important to take time to place correctly the lead appropriately and adequately the LV lead. And in post-implant, for sure, there is a role for a device optimization. Again, optimal pharmacological treatment is mandatory before thinking optimizing anything in our patients, and all of our patients should be on this pharmacological treatment. And I would even say ACE inhibitor and ARB most likely soon will be replaced by ARNI. So we have to take time to see if our patients are optimized pharmacologically, again, before optimizing their devices. And this is advised by the European Society of Cardiology and other societies. And you can see here, treating only the causes of heart failure, the causes of factors aggravating heart failure, maybe will resolve the problem without the need of optimizing anything. And you see here, we have to treat aggressively ischemia by revascularization, by appropriate drug, to control hypertension, to avoid atrial fibrillation, or how to manage. We'll see how we do this. Patients presenting with a significant burden of PVCs or non-sustained ventricular tachycardia, we have to think about new drugs like, for example, SGLT2 inhibitors and so on. By the fact only of increasing the neurohormonal blockade, by increasing the dose of ACE inhibitor or beta blocker and decreasing diuretics in our patients, most likely we will be able to improve their outcome. Regarding patient selection, if we are respecting this, if we are implanting patients presenting with really very wide QRS, we are talking about more than 150 milliseconds, those are the patients who will be benefiting from CRT. Look, the others, when it is less than 150 milliseconds in the main trials regarding CRT, here it's touching the identity line, so they will not benefit from CRT. Finally, who is the ideal candidate? Female are benefiting more when it is about typical left bundle branch block, when it's non-ischemic dilated cardiomyopathy, and with a shorter duration of heart failure patients. I do think that we should wait a little bit before implanting a CRT device in our patients, but not too long. From time to time, we are waiting for a long period, and the patient will evolve toward end stage of the disease. So keep in mind that those are the patterns of a left bundle branch block. For example, such patient, for sure, if he is already on optimal medical treatment, most likely he will benefit from CRT. And you see here, it's according to the recent guidelines published in 2016, wider are the QRS, more benefit the patient will get. And the cutoff was 130 milliseconds. I can remind everybody the story, when the story of CRT started, we were implanting patients above 120 milliseconds, and today 130 milliseconds, it's a contraindication for CRT. So now I come to the optimization of the device by itself. So during interrogation of the device, we have to get some basic parameters like sensing, like threshold pacing, but the most important ones is the percentage of biventricular pacing, we have to be sure that the therapy is delivered 100% of time. We have to look carefully at the memory of the devices, checking for episode of atrial fibrillation, for PVCs, non-sustained VTAC, and of course, we will have to optimize the AV delay and the VV delay. I would like just to stress something here. If you are interrogating the device and the device is telling you that the therapy is delivered 100% of time, it doesn't mean that the LV is captured 100% of time. And this is because maybe from time to time, even a slight dislodgement of the LV lead may lead to increased threshold, and the patient will not be receiving the therapy, even if it is delivered 100%. The LV is not captured 100%. We have to check for oversensing problem, for phrenic nerve stimulation. And this notion of left ventricular latency, I will show you here one example. You see here, this patient was meeting all the criteria for CRT and a device was implanted. And here is, you look carefully here at the biventricular pacing. The device was telling us that this patient is receiving 100% of time biventricular pacing. However, during checking the RV threshold, you can see that there is no difference, either biventricular pacing or RV pacing. The morphology is the same. It means that the left ventricle is not captured, even if the device is telling you that 100% of time the therapy is delivered. And this is the reason why we try to pace now the left ventricle only. And you see it's capturing. Since here in V1 it's positive, it's in a lateral position here, most likely posterolateral position, good position. But however, most likely this lead was implanted close to a scar or within a scar. You can see here how huge is the interval between the spike here and the QRS. And then even if the device is delivering the therapy, the RV is captured, so there is no place anymore for the LV to be captured. And this is the reason why this patient was not responding to the therapy. So this story of percentage of biventricular pacing is really important. And you see here, even if it is less than 80% of time, the outcome will be negatively impacted. And in patients with atrial fibrillation, if we are able to ensure 98% of time, the outcome finally is not too bad, because maintaining a high percentage of biventricular pacing, for sure it will attenuate the adverse effects of atrial fibrillation. If we are not able to control the fast ventricular response in patients presenting with atrial fibrillation, it's better to ablate the AV node junction and the AV junction, and you can appreciate here in red a patient in sinus rhythm. The outcomes is similar exactly as patient with atrial fibrillation in whom we ablated the AV node, whatever the parameter you are considering. The worst scenario is in patients implanted with CRT. They are presenting with atrial fibrillation, and the AV node was not ablated. Meta-analysis was done in such patients, CRT with atrial fibrillation, and it's definitely favoring the AV node ablation. It doesn't make sense at all if you have a patient with the CRT and you don't, if the heart rate is not controlled during atrial fibrillation, it's highly indicated to ablate the AV junction. What about ventricular ectopy? Many of our patients with heart failure present a lot of ventricular ectopy. Even with really a very low burden of PVCs, the percentage of biventricular pacing will significantly decrease, and we will not be able to obtain any reverse remodeling. So when the patients are presenting with PVCs, how should we manage this situation? So antiarrhythmic drugs is really a limited option, since all antiarrhythmics we are using are contraindicated in patients presenting with ejection fraction less than 35%. Amiodarone is one option. However, we all know the adverse effect of this medication. What about PVC's ablation? here in 2012, we have other studies, but this author here, Lucky Reddy, took patients who were non-responder to CRT, presenting with functional class 3, ejection fraction significantly reduced at 30%, biventricular pacing very, very low, 80% only because of a high burden of PVCs, and he did ablation in these patients. And you can see here, only 6 months later, the burden of PVCs significantly decreased, the ejection fraction improved. And regarding this situation, either atrial fibrillation or PVCs, it is recommended currently in the guidelines in AF patients to ablate the AV node. It's a 2A indication, and to ablate PVCs or non-sustainable ventricular tachycardia. It's a 2A indication as well. Don't forget that when we are talking about resynchronization, we have to resynchronize everything. The intraventricular desynchrony, the atrioventricular desynchrony, and the interventricular desynchrony. So with this regard, we have to optimize our device if we want to increase the cardiac output, if we want to favor the reverse remodeling. So let's start with AV delay optimization. I would like to share you this patient. I will not go into all details for the sake of time. This patient is 64 years old, presenting with non-ischemic dilated cardiomyopathy, ejection fraction 20 to 25%. She was referred for ICD implantation, but I can tell you here the medication is far from being optimal. So we start by optimizing the pharmacological treatment, but she was still presenting with ejection fraction around 20 to 25%. And as she was presenting with the typical left bundle branch block, so we decided to implant a CRT, and you can appreciate how nice now are the QRS. But still, even with this, and even with the significant improvement of the ejection fraction, she was still presenting with shortness of breath. She was still symptomatic. So we bring the patient to our echo lab, and this is what we found during the mitral inflow. You can appreciate here that the E wave and the A wave are completely fused. Not only this, you can see here, for those who are familiar with the echo, that this patient was presenting with diastolic MR. And we took time to optimize the AV delay, and this is the nightmare really for both electrophysiologists and echocardiographics. So you need to have an echocardiographer or at least a sonographer with you during doing this. So if you are programming a long AV delay, it's the same for our patients. The E wave and the atrial contribution to the diastolic feeling will be fused, completely fused here. If you are programming a short AV delay, the A wave will be truncated by mitral valve closure. It means that the mitral valve will be closed before the atrial contraction is finished. So it will negatively impact the stroke volume. The ideal AV delay is like this one. E and A wave are completely separated, and the mitral valve closure is not truncating anymore the A wave. And this is what happened to our patient here. Now you can see that the E wave and A wave are completely separated, and the click here of the mitral valve is not truncating at all the A wave. And you see here the diastolic MR disappeared, and now the patient is completely asymptomatic, and the AV delay was programmed at 120 to 80 milliseconds. If you ask me how should we do this, there is no magic formula. You have to do it step by step if you are still willing to do it by echo-based. But just remember and keep in mind that the optimal AV delay, what are we looking for, is the shortest one, which will allow the longest feeling duration, diastolic feeling duration, without truncation of the A wave by mitral valve closure. If you want to know if your diastolic feeling duration is optimal, you have just to measure here from the starting of the E wave to the end of the A wave and report to the RN interval, and this should be at least 40%. Okay, if you do this, you will be able to significantly increase the cardiac output. What about the VV optimization? We don't have strong evidence. We are really very lucky, like in such patients here. This is the native QRS. They are wide. With the CRT, they are still a bit wide here. But when we were pacing simultaneously both ventricles. But when we anticipate the left ventricle, here the QRS are narrow, but it's not working in everybody. And this is why the echo specialists tried several parameters, but not only one is working well. The most used one is the LVOT VTI, and we are decreasing -20, -30, -40, and you have to take the parameter which will allow you to have a highest VTI. It means that you will improve the stroke volume. This busy slide is summarizing all echo parameters. Unfortunately, is really time consuming, and two physicians will be stuck, the echocardiographer or at least the sonographer plus the EP. So we don't have time to do this. So if I don't have to do time to do this, I prefer that these things to be done by the device. And today it's a possibility. And all these algorithms here were studied in different trials. I will not go into all details, but the SMART AV trial, which is based on a SMART delay, which is an algorithm existing in Boston Scientific devices. So this trial was really a very smart one. So they compared here 1:1:1 empirical fixed AV delay, which was set at 120 milliseconds, versus echo-guided, as we did for our patient, versus a smart delay, which means that the device is doing everything automatically by itself. And what they found that there is no difference at all. It means this study should not be considered as a negative study. At least it's telling us that when it's done by the smart delay here, automatically by the device, it's not inferior to the echo. So we have to trust these algorithms, and in our patients who are not responders, if we don't have time to do it by echo, just open the algorithm. The algorithm will do everything for you. And the meta-analysis was done regarding all trials trying to address this situation. The result was neutral, but again, the device is able to do this by itself. We have to optimize our patients. Otherwise, the prognosis of non-responders is really very weak. In a recent published study here regarding the all-cause hospitalization or the all-cause mortality, the outcome is very bad. So what if we do everything and the patient is still non-responder? So we have several situations, none all of them are appropriate. You know, we fail in CRT because it is still anatomy driven, and we have to find the correct branch. It's not always easy. And currently we have up to 2 to 5% of our patients where we will fail to implant adequately the LV lead. So do we have a solution? We try to implant transseptally inside the LV, the left ventricle, the LV lead. So it's a solution. It is possible to do this. And the study was done and published in 2016. However, we are implanting the LV lead inside the left systemic ventricle, and this is associated with a high risk of thromboembolic event, including ischemic stroke. We don't know regarding the mitral regurgitation because the lead is crossing the mitral valve. What if the patient is presenting with endocarditis? So this solution was quickly abandoned. The future is this one, is a leadless CRT. We will be implanting a small electrode like this one, not exceeding 9 millimeter in length, and the diameter is not exceeding 2 millimeter, it will be inserted directly into the lateral wall of the left ventricle. And you see here, it will be quickly covered by the endothelium, so there is no need to give any anticoagulant to these patients. The patient will still need a co-implant device, a pacemaker, just a pacemaker, or ICD if you want. To insert RA lead and RV lead, and there is a need for a transmitter here, which is implanted to sense the time of RV pacing, and by ultrasound it will transmit the information to this electrode, and the electrode will transform ultrasound to electrical impulses to pace synchronously RV and LV lead. It's working, and actually you have the result here. It's even better than what we are doing epicardially when we are implanting the LV lead into the coronary sinus. The study was done. It's improving the ejection fraction. It's favoring the reverse remodeling. So it will be indicated in patients with a functional CRT system, but who are not responders. We can do this in this patient, or in patients where we failed to implant LV lead through the coronary sinus, or when it's programmed off. It means that we have LV lead inside the coronary sinus, but we are not able to use it because phrenic nerve stimulation, because high threshold, and so on, off, or this situation of upgrade if the venous system, subclavian, the innominate vein are completely thrombosed. So I will finish my talk here, and I'm going back to my first slide. Remember, I was asking the question, is this 30% of constant non-response, whatever the therapy we are applying to heart failure? Certainly not. We have a lot of things to offer to our patients. We have to optimize pharmacological treatment. We have to optimize the AV delay. It's really important. Is it because of non-optimally selected patients? I still do think, yes, we are still having a certain percentage of patients coming and non-responding to CRT. And when we turn the CRT off, actually, we discovered that the QRS are narrow. And in this situation, and if you are really facing such problem, it's better to turn off the CRT, because in this situation, it will be harmful. Because they are not optimally implanted, I would say yes, because it's anatomy driven. Is it because of a lack of optimization? The answer would be yes, and I advise everybody in red responder patients to trust the algorithm. They are working well, and they will allow you to optimize the AV delay without the need of doing it by echo guided. All this, we are assuming again that the patient is on optimal pharmacological treatment. With this, I would let you with this thoughts coming from Winston Churchill. Success is not final, failure is not fatal. It is the courage to continue that counts. It is really important. Success consists of going from failure to failure without loss of enthusiasm. So keep enthusiastic. And with this, I would like to thank you very much for your attention.
Thank you very much, Dr. Shahidi, for your very nice presentation. I think before moving on to the last presentation, we have 10 to 15 minutes for discussion. Is there any questions from the audience?
Unfortunately, no, but I have some questions. For Dr. Harbia, I have a question. In my practice, I use systemic NEP steerable lead to catheterize the coronary sinus to reduce the time of the procedure. And I use, in 1/5 of the cases, an inner catheter to do that. Do you use an EP steerable catheter to catheterize the coronary sinus?
Like I use it very rarely, because like you said, sometimes it's very quick. It will help you. You can directly calibrate the CS, okay? But using the catheters and just using the PAF and using the wire, sometimes it's very straight. When I have like hard time to find it, yes, I'm using the CS, the diagnostic catheter just to go to the CS.
In my
it will help, definitely it will help. It's quick.
Yes, very quick. In my practice, the difficulties that I find is in the patient who need upgrading from the right side.
Yeah.
Patient and with a huge right atrium, and I have this. In these cases, I have difficulties, and I don't hesitate to call my friends from the cath lab. They help me for some procedure like anchoring balloon, like some procedure that are specific to hemodynamic colleagues who do angioplasty, and I need. Sometimes I call them to help me, and they have some technical tips and that can help can help me to yes to put the lead, the left ventricular lead in the right, the best vein, and sometimes we do dilation, we dilatate when there is stenosis in the vein, and they help me to do that.
Yeah. So, yeah, it can be done, but you know, like I don't hesitate if I have a huge atrium or anything like that. I don't hesitate just to switch from one delivery system to another, just especially with the huge right atrium. I always try to switch. I don't mind switching from one and to another. And most of the time when you switch to another, if you see at the echo, you have a huge right atrium. But whenever you have the delivery system inside and you give some contrast, you try to know where is the coronary sinus. So you know how is the position. So once you have it, it's like, once I have it in mind, I change the delivery system and use another delivery system with all the different shapes and that we have, and most of the time it should work. Whenever you have a stenosis, we have some cases when you have really stenosis, yes, we did some balloon just to open the stenosis, and this is definitely, we ask for the interventional people to come and help, like you said.
Thank you very much. Question from Dr. Ben Amr and Dr. Habib.
Thank you. I have a question for my friend, Dr. Najmuddin Shahidi. According to Castle AF, which patient in atrial fibrillation are most eligible to ablation of EF than AV node ablation?
This is really excellent question. The problem with the Castle AF trial, we don't have all the details of the patients who were admitted in this trial. We guessed, regarding the excellent result obtained with this trial, we guess that we have a significant percentage of patients who were presenting with tachycardia-induced cardiomyopathy. And for sure, if it's the case, you will obtain excellent results by ablating atrial fibrillation before ablating the AV node. So my message here, why I advised everybody to ablate the AV node, the nature of the disease we are facing in our countries, either in Morocco, in your place in Tunisia, here in Riyadh, or on Lebanon, we are dealing with really very complex patients, and they are arriving between your hands in advanced stage. And to want to ablate the AF here, I think it's too late, because there is extensive fibrosis within the left atrium. Honestly, I'm not losing my time. I'm not losing my time. I'm just ablating the AV node, and that's it. In France, for sure, I was ablating in such situation. I was ablating the atrial fibrillation before ablating the AV node. At least I was given one chance to these patients.
Thank you.
Thank you. The last question, Dr. Hagi.
I have two questions, one for Dr. Harbiya and one for Dr. Shahidi. For Dr. Harbiya, one comment for your female patient, 63 years, with prosthetic valve and permanent atrial fibrillation. I have seen an atrial lead. I think this lead may be unnecessary unless you have we hope restore the science rhythm, which may be very difficult. And the next issue, when we implant more leads, we will get more complication. This is my comment. And my question, in case of failure of coronary signs, have you some experience with para-ECN pacing or a transseptal approach?
So just to go to this case, so this case was in paroxysmal AFib and has a dual chamber pacemaker, has tachybrady syndrome, then went into permanent AFib. So this is an old lead. No, definitely I don't implant an RA lead for someone who's permanent atrial fibrillation. There is no point. I don't have personal experience. I don't do his spacing. I don't do his spacing. I don't have any experience in his spacing in this case. So whenever, like, whenever we fail some cases, what we're doing, we're sending them to epicardial lead positioning.
Okay, for epicardial leads with surgeon, the problem is for ES4. Now we have no connection to, because the leads are bipolar, used by surgeon, are bipolar, but now we implant ES4. So we want to change the device, and this may be more cost will double.
Yeah, so basically what I do, like, I don't open the device in the case until I'm done with everything. So once I put the RA, the RV, and then like if we fail the LV lead and we decided to go to the epicardial, then we choose the device that we can put for the epicardial.
Okay, so we have an assist with two devices, OLED ES1 and ES4.
Yeah.
Okay.
There is no question for
The second question, Dr. Hagi, and
for Dr. Shahidi, do you have absolute confidence in the algorithm adjusting the AV and EV delays with all devices when patients are not responders? Do you trust really in the algorithms?
Yeah, definitely yes. I'm really trusting more and more this algorithm, because studies comparing data coming from device-based optimization and echo-guided optimization did not show any difference. Honestly, it did not show any difference. So I think we have to trust these devices, because we don't have time to do it ourselves. And it's really, as I mentioned before, it's a nightmare. You need an echographer to be with you, or at least a sonographer to be present with you, and you have to try, because there is no magical formula to use to find the optimal AV delay. This is the problem. And instead of this, when you are using automatic algorithm, it's helping you a lot. So I think we should trust whatever the algorithm coming from a different company. Honestly, it's working. It's working.
So sometimes we have very short delay, 50 milliseconds, and delay left and right ventricle delay 50 milliseconds. Not logical. Sometimes
you know what they are trying to do, and it's really very smart. And with smart delay, it's really very smart situation. Because you know what, in CRT, we are trying to correct an electrical problem, which is related to left bundle branch block. So what is the rationale behind pacing at the same time the RV? So if you are able to capture only the LV and synchronize on a spontaneous depolarization of the RV, it's really a good solution. It will save battery, and you will respect a kind of physiology. And the smart delay is trying to do this. And this is the reason from time to time, you will find that the patient is not in biventricular pacing. He is only in LV pacing. It doesn't mean that the patient is not synchronized. He is synchronized. By this smart optimization, we are pacing only the LV. We are correcting the main problem, the primary disease, which is left bundle branch block. So.
Okay.
Again, really, my message is really to trust these algorithms.
Thank you very much. I think we should move on to the last conference, which will be presented by Mr. Olivier Basile from France. He is a senior training manager in Boston Scientific Company. Mr. Basile will talk to us about strengths of Boston Scientific's discrimination algorithms and the new development in cardiac pacing and defibrillation. You have 10 minutes. You have 10 minutes. You have the floor, Mr. Basile.
Thank you very much. Good morning. So let me share my screen. So first of all, thank you very much for inviting me in such very interesting congress and very interesting discussion. And by the way, you know what? I am fully aligned with Dr. Eshadi comments, because I would like to give you more information regarding how to personalize CRT programming. And of course, the main challenge you face and we all face is the non-responding rate, the non-responder rate. So definitely a systematic approach is needed to improve CRT response. And it was already discussed, but of course, the proper LV lead position is key. The electrode, the position of the electrode is key. The vector, choosing the optimal vector. Today, modern systems, we have quadrupolar leads, so you have a lot of vectors. Difficult to choose which one. Optimizing AV delay, of course, smart delay, and multi-site pacing could be also a good, very interesting technique to optimize the responding rate. So this is why today I will briefly go back on the vector guide, on the technical side of the vector guide algorithm, the smart delay algorithm, and the multi-site pacing. So in terms of, let me minimize. Okay. So in terms of lead position, I think we all agree now the LV lead should be positioned in the lateral vein, mid-lateral vein, and apical position should be avoided, because even if the threshold is lower, the resynchronization is not the best. So definitely, thanks to MIDIT CRT sub-study, we definitely know that how to optimize basal pacing, meaning we should use electrodes who are located in the basal area. The distal electrode can be used, but generally speaking, when the vein is really tortuous, or when the end of the vein is going back in the mid-lateral area. So, vector guide, what is it? It's just a tool to help you to determine which vector is the best. Because of course, at the time of implant, you will probably test, let's say, 4 to 6 vectors, but you will not test all vectors. And the vector guide, just pushing the buttons, will give you immediately the RVS, LVS delay, meaning the impedance, the phrenic nerve stimulation. It's a very rapid test. Do you see phrenic stimulation? Yes, no. And LV threshold. You can also use what we call a fixed output, meaning the device will just deliver 2.5. Do you see capture? Yes, no. So you can rapidly populate all fields. And then, of course, ultimately, you will focus on the lead with the longest RVS, LVS delay. The vector guide is really key to identify the best of the 17 vectors you can program with the quadrupolar lead. So the smart delay is really, thanks Dr. Eshadi, because I think we are fully aligned. It's an algorithm helping you to rapidly determine the optimal AV delay. The test it's even shorter than 2.5 minutes. And the test is performed by the device, just one button to push. And of course, the objective of the smart delay algorithm is to recommend AV delays, best and sensed AV delays, providing optimally timed CRT, maximizing contractile function. So it's really, I'm going back rapidly, but it was already discussed on this clinical results, definitely we know that the response rate is the best when you use the vectors with the longest RV to LV delay. And you see here up to 82% of response rate if you select the appropriate vector. Such data are coming from the SMART AV sub-study. So definitely it's very efficient. So how smart delay works, I will not cover all technical details today, but the system will measure all AV interval, but meaning all intervals from atrial activity to right ventricular one and to the left ventricular one. After a sequence of sensed activity and paced activity. And of course, the device will also measure the VV intervals. And the system will use also, you need to mention, to enter in the device where the LV lead is implanted, meaning if it's a lateral or posterior or anterior area. All this information will be used to suggest the optimal AV delay with, let's say, promoting the fusion between the spontaneous right ventricular activation and the paced left ventricular activation. Very easy to program. Sorry, let me open everything. From the Brady CRT, the normal, it's a Boston example, of course, Boston device. So from the Brady settings, you have one button, you click here and you open this page. And the only thing you need to do is to adapt the temporary paced lower rate limit a little faster than the intrinsic rate of the patient, because the system will use this information to collect the AV delay after paced atrial activity. And then you click Start Test. And at the end of the test, you see the suggested settings. So the device will suggest the paced AV delay, the sensed AV delay, and the pacing chamber or chambers. And here you see by V pacing. So if you agree with the suggest, you push the button below and it will be automatically pushed in the normal settings. Then you just need to program. That's all you need to do. So of course, from time to time, if the conduction on the right side is good, but conduction on the left side is blocked due to the left bundle branch block, then from time to time you will see your device suggesting LV only. And here I know LV only pacing or programming is probably something a little challenging. So, and by the way, we probably underuse LV only pacing. Sorry for the sentence between in the parentheses, but why pacing on the right side if the conduction is good? As Dr. Aishaidi mentioned, you will save a lot of energy. You will, let's say, resynchronize properly the patient, even with LV only pacing. Even if, of course, then some concerns. According to the ESC guidelines, clearly we have a clear agreement that LV pacing alone seems to be non-inferior to BIV pacing. So clinically speaking, here we have, and we know that it's safe. We have clinical data demonstrating the safety of LV only. Of course, if the lead is dislodged, then no more resynchronization. But modern leads, spiral leads, are very stable because it was demonstrated that the stability of the lead is around 98% at 2 years. So definitely now modern leads are very stable and LV only pacing should be programmed probably more often. Let's say it's my opinion, but definitely why pacing the right ventricle if the right bundle branch is intact. So combined with vector guide and smart delay, then if you want to reduce the number of non-responding patients, then the latest feature we have in our device is multi-site pacing. multi-site pacing. Of course, today we don't have so many clinical data. It's too early. A lot of works are ongoing. Here you see the clinical study published by Dr. Zanon in 2016. And in his study, he was able to achieve up to 90% response rate using vector guide, of course, to select the best vector, using smart delay to optimize the best and sensed AV delay, plus multi-site pacing. And you see this high percentage of response. So again, I see multi-site pacing as a way to, it's one way, it's not the only way, of course, but to reduce the number of non-responding patients. So the concept itself is relatively simple, meaning vector guides will help you to eliminate vectors with high pacing threshold, out of range or inappropriate pacing impedance, and of course phrenic nerve stimulation. So you will, if you use multi-site pacing, you will use the first vector. Let's say the first spike will be delivered in the vector where you observe the longest RV-LV delay, so probably basal electrode. And the second vector, today the recommendation is to choose as a second vector the electrode with the widest anatomical spacing. More guidance. So of course, smart vector, one click to choose the vector, but then you have up to multi-site pacing, you have up to 216 vector combination. So definitely some help is needed, some automaticity is needed. And the system will be able also to suggest the offset between the two pacing pulses. So how to program? It's part of, in modern CRT devices, here it's a CRTD device, you see it's a Resonate device. You have here one additional feature, the LV multi-site pacing screen. You access this screen and then you follow the steps. You run vector guides, if not already performed. And then you click Smart Vector. Your system will automatically choose as the primary vector the one with the longest VV delay, of course, and then the widest, let's say, anatomically speaking, electrode up to right ventricle. So you can, the system will suggest the configuration. Then you can also click offset. The system will suggest the offset between the LVA, meaning the first pacing electrode, and the second one, the LVB, and then up to the RV. If you are familiar with the VV offset timing, the smart offset, the suggested is the sum, meaning here I see 5. It's probably because the device is willing to suggest 10 milliseconds offset between left and right ventricular pacing. So you see, selecting pacing order will turn multi-site pacing on and will allow you to program the LVB vector and timing offset. So it was very short presentation because I think the time is running fast. So this is the latest features we have in our devices, and they can be used to optimize the programming. And definitely smart delay is a way to optimize AV delay without echography, and it's not inferior compared to echo measurements. And the vector guide is here to help you because today we have 4 electrodes. So of course it's time consuming to check all electrodes. So it's done rapidly, one click. And then multi-site pacing. Thank you very much for your attention. Of course now I'm open for discussion.
Thank you, Mr. Basile, for this very interesting conference. We have time for one question. Dr. Hagi, unfortunately.
Thank you for this presentation. My question, when you recommend multi-point pacing for all patients or for selective patients, and when you begin the smart delay at implant or after 2-3 months later?
Very good question. And here I will follow the recommendation of Dr. Eshaibi. It's permanent optimization. Of course, every delay must be optimized at the time of implant, immediately after the implant. But then, even if the patient is responding to therapy, it's really good practice to run again the smart delay, let's say at least 2 to 3 times during the first year of therapy to adapt, because the situation may perhaps change. If the patient is properly responding, if we observe a remodeling process, then it's probably very good practice to run again smart delay and to readapt the best and sensed AV delay during the first, let's say during the follow-up. And regarding multi-site pacing, today we don't recommend to turn it on for all patients. Today we see it as a way to, let's say, to optimize non-responder patients. But again, more clinical data are needed, especially for patients with, let's say, ischemic myocardiopathy, because definitely wide spacing, inter-electrode spacing could be interesting if a large scar is present.
Sonia, may I add just one quick comment? Okay. Thank you, Olivier, for this nice presentation. Regarding multi-site spacing, you know, we have this option coming from different companies. Please don't open this option in all patients, because as he mentioned, with the Boston device, we still can avoid to pace through electrodes presenting with high threshold. It's not the case in with other devices. And if these electrodes are presenting with high threshold, the battery will not last more than 3 years or even 2 years from time to time. So be careful by opening this algorithm, and look carefully what you are doing with this multi-site pacing. The Boston device is smart enough to allow you to avoid these high threshold electrodes.
Thank you.
Thank you, Dr. Thank you, Olivier. I think it's time to end this session, which was very interesting, and I hope it was also instructive for the audience. A big thanks to all of the speakers. Thank you once again to the PAFCIC organizing committee and Boston Scientific Company for its support, and see you next time, inshallah.
Thank you so much.
Thank you very much.
Bye. Thank you.
Thank you.
Bye.
Thank you.
Bye-bye. Thank you.
Bye.